Hello and welcome to our webinar today, An Introduction to Integrated Primary and Behavioral Health Care for Social Workers. Today's webinar is presented by the Brief Intervention Group, or the BIG initiative, the National SBIRT ATTC, NORC at the University of Chicago, and NADAC. I will be your facilitator today. I'm Tracy McPherson. I'm a senior research scientist at NORC at the University of Chicago. If you have any questions or comments or any other burning concerns, issues, you are welcome to email me following the webinar. We'll also be glad to facilitate getting any additional questions to our presenter today. You can do that both through contacting me at the email address on your screen, as well as we can connect you directly with Dr. Salerno following the presentation. The webinar today is produced in partnership with the Brief Intervention Group, NORC at the University of Chicago, the National SBIRT ATTC, which is the National Screening, Brief Intervention, and Referral to Treatment Addiction Technology Transfer Center, and NADAC. Through our partnership, we are able to offer a full webinar series across 2014 that will run through August. As you can see here, we have already had some wonderful topics we've been able to present going back as far as December, maybe even a bit further, that really cross a number of different burning hot topic issues, both around the integration of screening and brief intervention as it applies to the affordable healthcare, and as well as how it relates to nursing and how it's integrated into criminal justice settings and other settings. And we've offered quite an array of topics for you, and it's made all of the education available to you for free. It's all posted at the hospitalsbirt.webs.com website. You can not only listen to the webinars, you can download the presentations and all of the handouts, and all of the education is free. And we are going to have two more presentations in the series. We have today's webinar, and we have one coming up which will be a little bit of a continuation of our topic today, talking more about why integrative care. You can download the flyer that you see on the left that has all the dates and the topics and the links, and links to registration. We really encourage you to share this with your colleagues on listservs and newsletters. Really our goal is to get this education out to as many people as possible. All of the materials for today's presentation, the PowerPoint slides, access to the free CEs and the CE quiz, as well as the archived recording, will be posted to the website. The PowerPoint slides are already there, and that is also at the hospitalsbirt.webs.com website. The CEs are approved by NADAC, NASW, NBCC, the American Probation and Parole Association, and they're accepted by OASAS. And today we're offering 1.5 free CEs. And again, the CE quiz will be posted. You'll see it pop up both in the chat box, but also you're going to be getting an email following the webinar giving you access to where all of the information is stored. In addition to the CE quiz, we'll be asking you to complete an evaluation form. The evaluation is really critical to maintaining the quality education that we have. It gives us really helpful feedback on how we're doing, and it also is really tied to us maintaining our funding, because we really need to know how we're doing. So we really encourage you to complete that evaluation form and take advantage of the free CEs. At the end of the presentation, we're going to have an opportunity for you to ask questions. As you see in the control panel over to the right of your screen, there's a questions pane. And so we encourage you, as early as when the presentation starts, all through the presentation to type in your questions, and it will maintain a running list for us. And when we get to the end, we will try to get to as many of those questions as possible. We will record all the questions, so if there's an opportunity for a presenter to respond to any of those after the presentation, we will try to do that. But if there isn't an opportunity, you're certainly welcome to, again, email me with your burning questions and see if we can get those answered. Our technical facilitator today is Misty Story. She's the Director of Training and Professional Development at NAADAC, the Association for Addiction Professionals. Misty will be behind the scenes, and if you have other questions or things about technology or CEs and those kinds of questions, Misty will be able to answer a lot of that behind the scenes for you. And our presenter today, it's my pleasure to welcome Dr. Salerno. Anthony Salerno is a New York State licensed psychologist with over 30 years of public mental health experience in inpatient and outpatient settings. Dr. Salerno has extensive experience in designing rehabilitation programs, working with families and consumer advocacy organizations, training multidisciplinary staff in the principles and practices of psychiatric rehabilitation, and providing organizational change management consultation to behavioral health organizations. In New York State, he has developed system-wide strategies to promote evidence-based practices with a particular emphasis on health self-management and family psychoeducation. Dr. Salerno was the lead author of the Wellness Self-Management Plus curriculum-based workbook that integrates mental health, substance use, and physical health topics. So it's my pleasure to turn the presentation today over to Dr. Salerno. Thank you, Dr. Salerno, for being with us today and sharing your experience. And I know everybody is eager to listen to you, so welcome.
Thanks so much. It's really a pleasure for me to have this opportunity to share some of my experiences in an area that I'm really very passionate about. So without further ado, we're going to get on to the program. Let's go to the next slide. Okay, so here are some of the objectives. And I'm not going to go too much into the first one around the Affordability Care Act, because that's been one of the programs that's already been offered to folks. But I am going to highlight those aspects of the ACA that will support and facilitate integrated health care. Some of the best practices around integration, and really the key role of social workers in an integrated care environment, which I'm really going to explain why that is such a critical factor, that if the profession of social work will play increasingly an important role, needs to be recognized immediately. And also review some findings from a project that we were involved in trying to answer the question, so how do we even begin to support the social work profession so that they'll have an integral and critical role in a changing healthcare system where integration is likely to become a foundational approach. Okay, so here's around health reform. And I do want to start out really with a polling question, just to try to get some sense of the audience out there. And if you could please do that, just to indicate your current knowledge, your awareness around integrated care principles and practices. Would you describe it currently as you have a great deal of knowledge in this area, you have a moderate degree of knowledge, you have some basic knowledge about it, or really not too much when it comes to understanding what integration means in the healthcare system? So if you can just take a moment to answer one of those four possibilities, we'll just wait a moment and then see what the percentages are out there in the audience. Okay, so we have almost half have a moderate level of knowledge. A small percentage have a great deal of knowledge. A lot of folks have some basic knowledge, and a number, 12% or so have little knowledge. Perfect. So I think with the understanding where the audience is, I think that this particular webinar will be able to address and may have this being productive for folks no matter what their response was in terms of their current level, of knowledge. So terrific. So let me go on to the next slide. So what's the problem? And now I'm going to be speaking about some of this data has to do with mental illness, but this is not so far away from folks with serious substance use problems. So in the area of mental health, the problem is that folks really dying a lot earlier than the average population. And the reason why I really connect to this is that I was very involved with the deinstitutionalization movement in New York State. So I worked for a very large psychiatric hospital. We went from having 1,500 inpatients to down to probably 300-400 inpatients currently. So during the late 70s, early 80s, that was a big part of the work that we did. And we thought it would be a great thing, right? Having people leave the hospital because typically they stay a long time. What no one anticipated, and we certainly did not anticipate, was that one of the consequences of having folks leave the large institutions where they may have spent many years was that there would be a really deleterious effect upon their overall health. The expectation that community services would be able to address some of these need areas, that promise was really not fulfilled. So when research was following folks who were not in the hospital any longer, they were losing between 15 and 20 years in terms of longevity. That really was a big wake-up call and a catalyst for taking this whole area of integration. How are we going to address this very, very challenging problem? Also, people with mental health problems also have many chronic health conditions. That was associated, of course, with reduction in lifespan. And 1 in 5 also have a substance use problem. So, and that was a very, very high-risk population. I'm sure that you work with clients for whom both substance use and very strong and difficult emotional factors, psychological factors, or really co-occurring disorder, mental health disorders is part of the picture. And all of you know that really does pose problems for the system and for this very high-risk population, and also going along with chronic health conditions. So this is a real big challenge, and the only system that was going to address the needs of folks with these multiple difficulties is an integrated care system. So the solution is, kind of bring this all together. So really, in a nutshell, is that we begin to look at systems where we can address in a coordinated way primary care needs, mental health, and substance use, really under one umbrella. Ideally, there are different levels of integration. I'll get into that in a little while. But this is the idea that currently our system is too siloed. We have mental health programs here. We have substance use programs there. We have primary care. We have then specialized treatment. We have hospital systems, residential, and oftentimes there's no integrated communication system, particularly to address the needs of some of the most vulnerable, populations. So the idea that folks have been looking at integration, and so one question, of course, as well, is that really the answer? Is that really going to solve the problem? Is that going to have the impact? And so some of the programs that have been exploring this is that for community-based addiction treatment programs, which you guys are much more familiar with, it does reduce costs, the use of emergency rooms, and the total medical cost. There's also reduction in some of the studies around like heart disease, and there's no reason to believe that we won't see reductions in any kind of chronic health conditions when we're able to coordinate care. So the Affordability Care Act, I'm not going to go through this in any detail. You guys have already had exposure, excuse me, in some of the previous webinars that have been archived. I'm just going to focus on a couple where that really provides an environment in which integrated care is supported. So in the area of coverage expansion, I'm just going to go to that last note there, that creating an essential health benefit package that provides comprehensive services, including mental health, substance use, that really has parity. And that whole area around parity and the expectation that with the Affordable Care Act, that insurance programs must be able to cover and support the needs of folks who have both mental health, physical health, and substance use problems. So that's a facilitating condition in terms of where the healthcare system is going. Also, when it comes to some payment reform, the really expansion of accreditation requirements to include a medical home health information exchanges. That's really a delivery system design as well, and a move away from fee-for-service to a case-based care or bundle-based care. Now that's going to be a really, really important issue. Right now, as you know, like for the most part, it's really fee-for-service. And every time you have a particular problem, then you generate a bill for that particular service, and it can just sort of like go on and on. In fact, the person who has more and more problems, you bill more and more for that individual. So that's a volume-based kind of system. The case approach is one in which you just say, look, for this person's particular health condition or set of health conditions, you get a sort of a lump sum sort of payment. And the system in place needs to manage the care of that individual in a comprehensive way with that amount of money. And so that usually is a catalyst for folks to making sure that they don't provide too much care, too little care, and that they don't misuse care, so that you really have optimal care. And that there's a lot of work done to ensure that the person is going to receive optimal evidence-based approaches where they're less likely to relapse, because every relapse in a case-based approach means more expense for the organization providing that service. So there's more conversations about ensuring that we don't have gaps in the system, because where you have gaps in the system, you have relapse in the system. Relapse is expensive, and so there's really trying to join together what is good clinical care with also what is good cost management as well. So the three aims, and I'm sure you guys have heard this before. So what's the point of all this hoopla around changing our healthcare system, our insurance system, and the way in which we deliver healthcare in this country? Part of it is to have some control over costs, because it's kind of out of control. The second thing is that not only can we deal with the issue of cost, but at the same time to improve quality. And it may seem like, well, you get what you pay for. But in the healthcare system, there are things that really organizations can do, and we can redesign things in a way that we can both reduce costs and improve care. Just throwing more money at it will not do it. And the other issue is to improve outcomes for large populations of people, is really having a population-based kind of like perspective. So the folks who are at the highest risk, the folks that you treat, folks that you work with, who have substance use problems, physical health difficulties, often other mental health challenges as well, then all the other kind of social net kind of challenges in terms of a person's, just sustaining their day-to-day living. All of these things really coming together. And can we design a system where we can really address the needs of folks in a very effective way? Okay, so some of the components of integrated health, IH, right? Key components. And just to make a few points here. The idea is really to establish this ongoing relationship with a physician, with a clinic, with providers that's really continuous, that's coordinated and is continuous care. So you're not forgotten about once you leave the exam room. Where you have also a client who isn't a passive recipient of treatment. And I think all of you know it out there, that unless a client is an active partner in addressing whatever the problem is, whether it's substance use related difficulties or it's mental health or it's physical health, this is not accomplished by having a client who's in a passive position. But activating clients, having them engaged in this process is not just a nice thing, but really a critical thing. The whole person, that we just don't chop people up into their sort of brain, their mind, their physical body, their substance use. For others, it might be like trauma. But the idea of like cutting up people into different parts, because our system happens to be cut up into different parts. But this notion that really, no matter what part of the healthcare system an individual goes to, someone's paying attention to the whole person needs. And then the idea of a team working with clients, levels of care that look at the acute and chronic and preventive sort of strategies. Of course, the idea of ensuring that the services really make it accessible to people across different cultures or different health conditions, that it's coordinated, integrated, of course, we're really highlighting, where all of the quality issues around safety are enhanced as well, and that the payment system really kind of supports an integrated healthcare system, which is really continues to be a challenge, but continues to move along, as well. Okay, I'm going to use this frame here. It looks a little busy. I don't want to make it busy for you. The point I want to make with this is this. When someone says that of a program is integrated, it's not like you're integrated or you're not integrated. It's not a black and white, yes, no type of thing. There's a continuum of integration. I think it's important to recognize. Everywhere from, like, take level 1. There's some collaboration, even if it's at a distance, with some healthcare providers. So one of the programs you're working in, if there's a healthcare provider down the block or a federally qualified health center or a hospital program, and you've kind of reached out to them and try to establish a connection so that your clients could be served by this particular healthcare agency, but they're not really, you can't call it integration. It's mostly some level of collaboration and communication, but it's really at a distance. That's a pretty low level in terms of integration. You get much better at level 3 and 4, where now you have folks that may be on site. And many of the programs that I work with at the National Council, about 30 organizations that are part of this large grant around integrated care, they typically been able to establish a relationship with a healthcare provider where the healthcare practitioner comes to the behavioral health program on some basis, and they are able to see clients really on site. So that's, of course, kicking it up a little bit. Then you really kick it up when you have very close collaboration, and at times actually having a merged, integrated kind of health record where there is a team that includes a healthcare provider, a substance abuse specialist, and mental health. You can really talk about a nurse, a nutritionist. You can think about an expanded kind of interprofessional team that's all using the same medical record, communicating on an ongoing basis. Now, when I've interviewed clients who have been in some of these really pretty good integrated care programs, what the most common thing that I've heard from clients when I ask them, so what's different now that you're in this type of a setting as opposed to where you were a year ago? And I've often heard them say, Dr. Salerno, it feels like I have like a team, that I'm part of like this team, like there's a group of these people who are kind of watching out for me, and that they talk to each other. And that I know that they talk to each other because when I see them, they make reference to the conversations they've had with my other, provider, my mental health provider. And this notion of having like a team and the clients experiencing that kind of a process, then I know that that's a really high-level integrated, program. When the client's experience is one in which they are part of a team and people are looking out for them, and that they're talking to each other, and that they're coordinating their care. So that's the highest level. Now, what I want to focus in on is this. So, all of us out there, I'm a psychologist by training and have a lot of social workers out there and others perhaps from other disciplines. So we're talking about, so what is it that you really need to be able to do? Do you need to learn anything new if you're going to be working in an integrated setting as opposed to what you're already doing? And that is a really important question. And so one of the areas that we've been exploring, and we've been working a lot with schools of social work really around the country, and also looking at what are some of the demands and the tasks and challenges, the competencies that would be needed for someone like a social worker who's working either in a behavioral health program where they're bringing in primary care, or they're in a primary care setting that also includes behavioral health services as well. And in either case, we're really kind of thinking about what were the core competencies. And social work, one of those professions where the issue of values is very, very core to the social work profession. And I'm a psychologist, and not that we don't have important and good values as well, but I've been very impressed now that I've been associated with the School of Social Work, how seriously the notion of having a value-based approach to the profession. And so I'm going to speak a little bit about the values, the kind of knowledge. So what do you need to know? What does a social worker really need to know so that they can practice in an exemplary way in an integrated health setting? And what do they need to be able to do? So one is a knowledge base, but the other is, what do I do? What are the actions? What are the behaviors? What are the skills that I have available? So let me talk a little bit about that. But before, so I'm going to go through three major areas: value-based approach, knowledge, and then skills. But what I want to do before that is ask you to, now you would have to type this into the question box. And what I'd like you to do, so it's not the chat box, it's the question box. From your vantage point, since you have so many social workers out there, what are the most important values that guide your profession? And if you could just share that a little bit, just it could be a one-word or brief sentence, if you could just type that in. And I wanted to see if we can get a compilation of some of the core key values that guide the profession of social work. So I'm seeing empathy, integrity, respect, dignity, confidentiality, compassion, social justice, really respect for the integrity of the individual, the person-centered approach, self-determination, acceptance of a client, equity, positive human, focus on the relationship that people have, human dignity, honesty, strength-based approach, empathy, and social justice. That's what's coming up over and over and over again. Being authentic, being guided by a set of ethical principles. Now that's really terrific. And you guys really, really hit it. The cultural competency. A lot of this is really focused on the nature of the relationship. And so I want to just appreciate that. And really, when a profession is guided by values, that's very, very powerful because one begins to examine the services that are being provided, the needs of the clientele based upon those values. So let me share with you some of the values that we've also been able to compile. Well, many of them just align perfectly with what you guys had. It's perfect. So one idea is that looking at the system. Now this is a little bit in contrast to my profession, I have to say, although maybe some psychologists out there who might disagree with me. But we tend to be so focused on the individual and sort of the psychological life of the individual that we can sometimes, or not as much, really appreciate the context and the system in which people are living. Their context has such an important factor. So that I know is very, very strong for social workers. The notion of comprehensiveness is that the entire, look, it really has around the whole person, which is some of the responses folks have had, looking at the environment and environmental values. The cultural sensitivity that you guys have also typed in as well. The whole health, which is really looking at human beings, not chopping them up into various ways of functioning, but the sense of the needs of the entire person. And that would cut across physical health needs, the needs around basic survival day-to-day in their lives, emotional difficulties, substance use, all of those things coming together. Person-centered and self-determination, I saw that over and over again as you guys were typing that in. Having access so that we don't create these barriers. Social justice is very big in that, right? And the idea of equity and social justice, you guys repeated that over and over again. Well, my look at the things you guys have typed in, and the idea of working with a team, with a collaboration. It's not the emphasis on the individual kind of practitioner meeting once a week for a clinical session, but rather the idea, particularly for the clients with the most complex needs, is that that's the whole team. Perfect. So all those values, and I think these values, and the reason why I wanted to emphasize is I think it lines up perfectly with integrated care. That integration and the values that social work profession advances very, very strongly is really has a great alignment to it, and I think that's important to recognize. You guys are incredibly well suited to be playing an incredibly important role in an integrated healthcare system. So now I'd like to move to, so values is a set of guiding like principles, but then we need to know stuff. And so what is it that social workers need to know? So that we've come up with these 5 areas. Again, this is from conversations with a lot of folks in integrated care settings, speaking to faculty in schools of social work, I'm here at NYU, where I'm affiliated with the School of Social Work at NYU, and I've been teaching classes there as well. So here are some of the things. The one thing in an integrated system is you got to see the connection among mental health, physical health, and substance use problems, is that you don't just see it in a myopic view. I got to be honest with you, when I work clinically in psychiatric hospitals and clinics and day programs, I've probably worked in as many programs as they are in New York, and our focus really very much was like mental health. And I kind of zeroed in on that. You know, substance use was kind of like a side issue, and if folks had it, we used to try to refer them to a substance use, program. It never worked at all when we disintegrated services. It just never worked. And physical health, well, we kind of knew that it was important too, but we really zeroed in a lot on the mental health. That was the core issue. And I think we kind of didn't see the interdependence, among all of these things. And so that's one area of knowledge, is that when you see a client, you haven't divided them up into pieces. The role of adverse life experiences. This is an increasingly important area. The data is pretty strong that the more adverse life experiences folks have had, it increases the risk around every problem area. You name the problem, if you've had adverse life experiences, it put you at higher risk. Substance use, mental health, and a whole host of chronic health conditions, which is actually quite startling, the research that has been done in this area. That how could something that's happened before the age of 18, somebody who's like 50 years old, how can there be a correlation between those adverse life events and a chronic health condition? As it turns out, there is. So, we're beginning to be more sophisticated in our understanding of the factors that contribute to a person's current functioning. Also, you need to know if you're going to be part of an integrated team, and it seems that really is going to be core. You can't do integration without having an integrated team. Understanding the roles and functions, like what do these folks do? I mean, I couldn't tell you exactly what is it like a nurse practitioner does versus a physician's assistant, a nurse, a medical assistant. What are the various roles and functions? What is a health navigator, a peer specialist? I mean, there's a whole host of folks who could be on a team, and really kind of appreciating and understanding what their expertise is an important piece. The culture of primary care. We in behavioral health, both substance use and mental health, we develop a certain way of doing work, our assumptions about what people need. And in primary care can operate on a different way of looking at the work, the way in which the workflows are organized. So primary care, understanding that culture of primary care would be really very important. And then having some basic health literacy so that we have some understanding of a variety of health conditions, that particularly those that either influence, put people at risk around substance use, or the way in which substance use can harm a person's physical health, and the way, again, as these things begin to work together. I'll go into a little more detail on each one of these things, just a tiny bit. So around understanding the interdependence, right? So we know a few things, that persons with mental health problems have a higher risk of health problems, smoking, obesity, physical inactivity, higher rates of diabetes, arthritis, asthma, heart disease, and in chronic disease and mental illness have higher costs and poorer outcomes. For folks who are for substance use, raises the risk for a variety of mental and physical health problems, hypertension, liver disease, depression, sexual dysfunction, various forms of cancer, HIV. Well, and you guys know this, right? You know your population, you know a lot of the health conditions, but they're mutually interdependent in a way. When an individual has to struggle with all of these physical health conditions, fatigue, pain, discomfort, increasingly little activity, all lethargy. I mean, there's all sleep problems. I mean, there's a whole host of things that, again, puts them at a disadvantage in terms of trying to address some serious substance use or mental health problems. So one of the best strategies to address mental health and substance use problems is to take care of your physical health, and vice versa. And that's where the idea around this interdependency, which is a conceptual model that I think people in the helping professions, increasingly that's going to, I think, be the approach that we're going to all need to take. And training of professionals will increasingly focus on that as well. The other is the idea of understanding adverse life experiences. I'm involved with a national project for a few years now on how to help organizations become trauma-informed. And this is like a really important area that sometimes gets missed. I hope that's something that you guys have been exposed to, or I think it's a very important thing. I wish I had more of this when I was back in the day doing clinical work. So I didn't really explore the degree to which people's adverse life events may be contributing to their current, life difficulties. So this is an area that, again, helps us to approach the individual in a comprehensive way. And so what do we know? The research is pretty clear on this, and we're not talking about it with a handful of people. The research that's been done on really tens of thousands of individuals, just taking a look at the correlation between people having bad things happen to them, particularly before the age of 18, everywhere from neglect to abuse to the loss of loved ones early on, to living in a household with as a parent with mental illness, or someone who's incarcerated, where there's been homelessness and food insufficiency, a host of just the stuff that we know that is really very difficult. And if you have to deal with that when you're young, that's even more difficult. And when you begin to look at the correlation, you get really astounded by some of these things. So that these multiple trauma experiences, the more of these events that you've had to deal with, really stresses a person's coping capacity. So alcoholism, obesity, respiratory difficulties, you can kind of go down the list, right? You name any negative outcome in terms of dysfunction on a psychological or physical level, you will see a relationship, a risk relationship between the number of adverse life events and some of these poor outcomes. So now understanding the roles and functions of an integrated team. I'm just, I don't have to go through this very much, but being sort of aware of really what the difference is between what do nurse practitioners do, physician's assistants, doctors, behavioral health specialists, substance abuse counselors. This list is also for the folks in the primary care, because the primary care folks need to kind of have a better understanding of what behavioral specialists are all about. There's a difference between, what psychiatrists do, what mental health and substance use counselors do. There's also care managers and health navigators. You'll see more and more of this. If there's going to be one role that you'll see increasing beyond the role of traditional case management, will be this idea of a care manager or a health navigator, who is often the one who's at the hub of this integrated wheel. This is the individual, because when you think about it, who the heck is keeping an eye, who's overseeing this whole thing? The client has a tough time if they have to relate to 3, 4, 5 different systems. So relating to a core person, the individual who's at the hub of this therapeutic wheel, that is going to become increasingly an important role. And social work is so well positioned to play a major role, both in terms of developing the kinds of skills and approaches around health navigation, or supervising folks who are in that particular field. It's going to involve reaching out and involving families, community resources, the internal programs that the client is involved in. That role of the person who helps you to navigate what is often a very complex system, that is going to be not a nice thing, but really, really, really critical. What profession is in the best position to really formulate and design that role and to ensure that it's implemented effectively? I think it's the social work profession. Okay, so let me just kind of go on. And then there's peer health coaches. You're going to be hearing a lot more about this. Some of you may already have peer specialists who work in your program. Some of you may not. I've spent a lot of years in psych centers where I was working with peer advocacy organizations that came into the hospital or into our outpatient programs to provide peer-oriented services. But the role of the peer can be really very, very special. In some of the work, there's increasingly a recognition around in mental health and in substance use that peer-led disease self-management interventions are going to be an important part of the menu of services available to folks. There are some special things that peers can do in terms of engaging clients that we as professionals may not be able to do as well. And I think you're going to see increasingly the role of peers and understanding what their role is, how you in your profession can support, how a person becomes part of a team, that we all work together. That's going to be an increasingly important area. Also, what do LPNs do? Licensed practical nurses, medical assistants. If you have nutritionists or you have occupational therapists, some programs actually have a personal trainer. There's some programs. It's actually these programs where they begin to really engage individuals when it comes to the area of like exercise, weight reduction, nutrition, where there's like an individual who helps you along. Some programs have used peers, who have really done very, very well and get some kind of a certification in peer, in sort of personal training, that kind of thing, which is not as extensive as you might think. So I've seen where programs, have done that and included that kind of an approach. And there may be other sort of related professions that begin to emerge as well. You're also understanding the culture of primary care, and what does that really mean? We kind of do things a little different. I'm not as familiar with substance use programs, although I work very closely with the OASAS in New York State, our Department of Alcohol and Substance Use, around developing some curriculum-based approaches that integrated mental health, substance use, and primary care, all within a unified curriculum. And many programs, substance use programs in New York State have used that. And so I've gotten an education from working with folks in the substance use programs, and it really aligns very much with my experience around mental health, that we tend to be a little more process-oriented, a little more long-term planning and coordination. We kind of look at things as a very highly individualized approach. We look at a variety of evidence-based approaches. We're really looking at risk related to the client's self-harm or harming of others. These are just some of the things. But in primary care, they really, they work quickly. And oftentimes one visit, you got to kind of diagnose what's going on and then come up with some sort of a treatment or referral to specialty services. But it's kind of more, it's rapid. It tends to be more problem-focused, immediate kind of solution. Productivity is really measured in terms of number of patients seen. There's a certain kind of flow to support the primary care provider. They've actually done estimates on this, so that needing to see 18, 20, 25 clients in a day in order for it to be just fiscally viable. Those are some of the realities. What your patient volume needs to be, and so the work tends to be quick. I've worked with patients for many years, and could see them on a regular basis. That's increasingly going to change, not just because of sort of an increasing kind of focus on integrated care that might be a little brief, but also because of managed care and increasing emphasis to avoid the misuse and overuse and underuse of services, but particularly the overuse of services. Using evidence-based practices is like the key. Like what's the best treatment for this particular kind of condition, and that's very much a major focus. And then risk and liability concerns rather than necessarily the risk or harm to the client. Now these are just some particular things. What I've been most impressed with is that primary care is really looking at rapid, kind of immediate solutions, quick diagnosis, having a treatment at that point in time, or following up with some tests so that you can extend the diagnostic process. And we tend to be much more in a initial phase of developing relationship, having a broad overview of the individual's life difficulties. That's different. And when folks come together, they need to just appreciate some of those differences. So these are some of the knowledge base there. And then also some health literacy, right? So do we even know what a body mass index really means? Do we know about blood pressure when it's really just not too bad versus when it's at high risk? So would you be able to even, are we comfortable and be able to even read lab results? So that we have, or if we're talking to primary care and they're sharing some information that puts the client at risk, do we have an understanding of what they're talking about? That kind of a thing. Looking at the person's various habits, which is the sort of lifestyle factors around smoking, around exercise, nutritional habits. That's an area really around health literacy. Did I ask those types of questions when I did my clinical work? Absolutely not. I just didn't do it. And this goes back, but integrated care begins to bring some of these basic kind of knowledge areas into the work of helpers. if you're in a helping role for people who have life difficulties, these are some maybe basic areas of knowledge that can be helpful. Certainly you guys are experts in the area of the substance use and the alcohol use, but if people are in pain, they're kind of living, their lifestyle kinds of issues is very, very important. As it turns out, just having access to primary care, we hope that that would really do the trick, right? That clients would benefit to such a degree that we would actually see a reduction or at least an expansion of longevity over time. If we're talking looking years ahead, that we start finding that people are decreasing their smoking use. Smoking among people with psychiatric problems, and I'm sure this is something you guys know as well with the substance use population, it's just very, very high. The non-psychiatric, the non-substance using population, talking about street drugs or alcohol kind of abuse, there's been a reduction in the general population around smoking. Certainly in mental health, we've seen no reduction. And they account for such a huge proportion of individuals who smoke. So those kinds of things, instead of it, if we're working behavioral health, we think, well, our focus is either substance use, and certainly I know that the substance use programs are beginning to regard smoking as another misuse of substances, right? And so that becomes like another focus area as well. Okay, so I have a polling question for you. So these areas of knowledge, right? Which area do you believe is most urgently needed? For let's say across the board for social workers, that you really think this is really the area we need. Now you have 5 choices: that whole understanding the interdependence, the role of trauma, the roles and function of a team, the culture, understanding the culture of primary care, or really having basic health literacy information. What would you say, in your estimation, do you think is the most that we really need this as a social work profession? This is an area that we really ought to concentrate on. Just give you a moment to fill that in. Okay, so the majority kind of view, and it's kind of interesting. It's like, let's go from the sort of the basic foundational idea, is do we even appreciate the interrelationship and view this as something that's important in our role? So that's where you have about almost 40%. The role of trauma for 14%. Understanding the interprofessional team, 28%, and the others around 10% or so. But what stands out is really understanding conceptually that the role of a helper in a comprehensive way, whole health approach is something really important that we need, and perhaps you'll have more opportunities to learn more about that. I think that we're going to increasingly see that, certainly in terms of the schools of social work, and I'll be talking a little bit about that, as well. Okay, thanks so much, folks, for filling out the.
Looks like we've lost Tony for just a moment. If everybody will just bear with us, we'll get him back on the line.
Well, while Misty is working to get Tony back on the line, I wanted to mention a couple of things that the Brief Intervention Group is doing, and we are working with a number of organizations who are really focusing on the integration of education around screening, brief intervention, and referral to treatment in the training and professional development of young social workers. And we're also, have a similar collaborative effort going on in the field of nursing, and in some cases it's nursing and social work departments working together around interdisciplinary training and team-based training. So I wanted to mention just to folks, as you're looking for communications from our initiative, and the work that we do is generally published in a newsletter called the SBIRT Update. So if you don't currently get that and you are interested, you can certainly send either myself or Misty an email, and we can get you on the list. It's a closed list. But in that communication, we update on some of the learning collaboratives that we're organizing around pre-service and professional development of social workers. We're also doing the same around nursing, as I mentioned. And we're going to, with the intention, hopefully, of growing that so that we build not only schools of social work who are already being funded and schools of nursing that are already being funded under the SAMHSA funding mechanisms, but also we want to be able to grow that to include schools of social work that aren't funded, that they're trying to really integrate screening, brief intervention, education into the core coursework that they're already doing. So we're not trying to sort of snap on things here and there and have an extra thing that, you know, everyone needs to teach, or a requirement that everyone needs to teach, because we know that the curriculums are already packed full for sure. But what we want to do is really work from the ground up with a learning collaborative of schools of social work to say, how can this be integrated into the coursework that you're already doing? So we hope to have more in our newsletter about that learning collaborative, about some of the activities. We hope to be able to have monthly or quarterly learning collaborative meetings where we stimulate conversation and help grow this initiative to reform how we can help the schools integrate this important education without creating more burden on the schools already. So we hope that you'll follow us around that initiative and get on our SBIRT Update newsletter. Let me check in to see whether we have Tony back on the line.
Unfortunately, no. I think that we've lost all contact with him. We're having some technical difficulty right now that I'm not able to resolve.
Okay, well, let me also, while we're trying to resolve that, let me look and see if there are any current interim questions that have been posed that we might be able to give some answers to. There's been mostly a lot of interactivity with the polling questions and some folks sharing about where they're working and in different types of settings and things that they're working on. Let me see. We do have a couple of folks interested in getting on the email list, the SBIRT Update, and I'll give folks the email address that you can email me, which is esap1234@gmail.com. So that is, let me put that into the box here so everybody can view that. And that should come up shortly. Here we go. And I'm also going to provide the web address where you can actually go online and sign up yourself for to join the initiative. So here is my email address. You're going to see that being posted any second now. There we go. And let me give you the address for where you can join. We have several initiatives, actually. We have one initiative that has been really focused historically on behavioral health professionals, workplace behavioral health professionals that include employee assistance program professionals, professionals who are out in the provider networks, about 90% of which are coming from the social work field. And that group is called the brief intervention group or big initiative for EAP professionals. And I'm going to put in here the address where you can sign up if you're particularly interested in that group. Okay. Then we have the second group. So if you are working in medical settings, we have a group that we call the Big Hospital Initiative. Even though it's hospital specific, we've really grown and expanded. So social workers and nurses and other types of clinical professionals, as well as researchers and experts in the area, really interested in how to integrate screening and brief intervention in their practice out more in medical settings. We have a different initiative that is really designed around that, and we have quarterly calls for both initiatives, and we have separate websites as well. But I would say that I would encourage you to take advantage and look on both websites, because there's a lot of unique content, a lot of resources about how to implement screening and brief intervention in social work practice. There really are an infinite number of free resources, as well as the entire series on how-to, a lot of the how-to series of how to do screening, how to do brief intervention, referral to treatment, as well as topics around SBIRT for marijuana use. And we have several in our series around that topic, as well as around prescription medication misuse and opioid risk. So these are really designed for a broad range of professionals, but much of our constituents are social workers, so I think you'd benefit greatly. So I'm going to put a couple of web addresses in here, and Misty's still working on trying to bring back Dr. Salerno onto the webinar. And then I'm going to post the second one. All right. Let me see if I can find an update here on, well, it looks like we have Tony back on the line, and he is moving through the presentation, but I don't think he knows that we are not able to hear him. So let's see if we can get Tony back. While we try to get Dr. Salerno back on, I'm going to look again at a couple of other questions that folks have, so we'll take an opportunity to see what else has been posted. Feel free to post your questions here as we're waiting. We're going to try to get Dr. Salerno to dial back in if we can get his attention. Let's see. Okay, any questions here? Let's see. Well, we have a question about the particular curriculum that Dr. Salerno was talking about. And what we'll do is we can pose that question to him about, are there specific graduate schools of social work that are implementing the curriculum? I'm sure we could probably find that out for you. He's been one of the authors of it, and I'm sure he must have a good sense of what schools are currently integrating it. So we will, I think we can definitely get some information for you for that. Let's see, does the website offer information on where social workers already in the field can find information? Yeah, so if you're referring to the Brief Intervention Group website, the hospitalsbirt.webs.com website, and the bigsbirteducation.webs.com website, the information there is, I would say, most of it, the majority of it, is information for social workers already in the field. There's a lot in there, a lot of rich information, some terrific speakers talking about their experiences on the ground, working in a range of settings, from primary care to criminal justice and workplace, FQHCs. Really, there is just a range of settings, and the materials are really designed, have been many of them designed for folks who are already out in the field. So yes, a lot of what we try to do is make the tools available, accessible, and able to implement. You know, one of my goals is to have something ready that people can try to implement the next day after they go through some of our training. So these are ready-to-use tools. So if you're looking for something in particular and you can't find it, you're certainly welcome to email me. But yes, many for folks already in the field. We also have on those sites, we have several different curriculums that have been developed for a range of professionals. We have what we call the Brief Intervention Group SBIRT curriculum, and it's been adapted for specific audiences, particularly because we're trying to tailor the information to context. So we have an EAP, an Employee Assistance Professional, EA Professional, and Behavioral Healthcare Professional Guide to Screening, Brief Intervention, and Referral to Treatment. And that is posted on our website. And I would say that's really for quite a range of professionals, but you could use it to implement with schools of social work. We have had requests from schools who are wanting to get a copy and try to take chapters or modules around the different screening tools, different approaches to providing brief intervention. There are different models of brief intervention. There are some sample protocols of how to actually do it. They're just taking modules and trying to implement them into their general coursework or specific specialty coursework. And that guide could certainly be used, you know, for a range of, I would say, undergraduate and graduate social work students, as well as professionals that are already out in the field. We also have a adaptation of that version, which was designed more around health professionals working in more traditional medical settings. So it's sort of written more with the mind that nurses, nurse health educators, physicians, other medical clinical types would would be implementing. That said, it could be used in a social work program to educate students about screening and brief intervention, how that's integrated into medical environments. And there are some slight differences. Certain models of brief intervention are discussed in more detail because we find that certain models like the brief negotiated interview or the BNI really has been used a lot in medical. So a social worker going out into the field in a medical setting may be more likely to be exposed to that model. So that version of our curriculum is posted. And we have a third version which has been adapted for addiction professionals. And so addiction professionals and other types of professionals, I imagine could be used for peer health educators and recovery support advocates, social workers working in those types of settings. It could be used both in pre-service professional development, workforce development settings, as well as post-graduation, already working in the field. So I would point you to those three, all posted at the big SBIRTeducation.webs.com website, and you can cross-link to the different websites and get you there. It probably is under a tab called Learner's Guide. Learner's Guide has will probably have postings of all three that you can link. And we also have the table of contents and kind of a snapshot. You can look inside to see what it's about, and you can order it. We make those available through NADAC. So let's see what other questions. Let's see if Misty's had made any strides in getting Dr. Salerno back on. And not currently. So let's take a couple more questions, and we may just not do as many questions at the end if we can get him back on here. Let's see. There is a question about this person, excuse me, is working for an integrated healthcare addictions program in Westchester County of New York, and they're interested in finding out where these programs are located. So I think we could probably get that answered for you as well. So I will take that question to Dr. Salerno afterward. I'm sorry I don't have the information to offer you at the moment. Let's see more about trauma-informed. What resources are there to learn more about trauma-informed care? Is there a curriculum? Well, we'll certainly post that to our presenter as well, but I know that some folks have been working in that arena, have gone to the SAMHSA website and have been looking at resources that have been posted there. They've been doing work around trauma-informed care. There are other organizations. We could pull a couple of resources and links to some sites for you, and we'll post that in the Q&A document that will be posted to the website, because there are some I think some key organizations or agencies that are really doing some work in this area. I know there were some centers. We were doing some work with Georgetown University, where they have trauma-informed care research center, and I'd be glad to take a look and see whether their work is still ongoing and what kind of resources they have. That's the one I'm personally most familiar with directly. And let's see, other questions here. Is there any research showing how effective SBIRT is? Yes, there is. And I should qualify that by saying that most of the research around SBIRT and the evidence around SBIRT has been done around alcohol use. There's a lot of evidence to support its effectiveness. We are still looking at the results and the evidence and the research around applying the SBIRT model around substance use in terms of drug use, illegal substances, as well as prescription medication misuse. In fact, there are clinical trials going on across the country. Yes, hi, Dr. Salerno?
Yes. Did I get this? It seems like I've gotten disconnected. Do you know what point I got disconnected?
I think right where you are, where the slide that I see in front of me about the poll question. I think that is where.
Okay, great.
Yes.
Okay. Are we able to bring up the poll question?
Misty, are you able to pull up the poll question?
Yes, we'll resume from here.
Oh, okay, great.
Great, thank you.
Sure. Okay, great. Okay, so which one do you have? Let's see. Okay. So we just have, I guess, 5 options there, which is fine. Okay. All righty. So this one, we have a little different distribution. There's really a number of areas where folks think that, gee, we could really do some more work, particularly on the engagement, connecting, and motivating skills, as well as the comprehensive care coordination. Certainly, people feel more comfortable with some of the basic cognitive behavioral interventions. Terrific. Some of the brief, certainly with SBIRT and integrating screening and assessment skills. So that's terrific. That folks, that you have a good foundation, and now it's how do we increase that? Perfect. Thank you so much, folks, for sharing that. Now let's see. Okay, I'm back on here. Okay, so what are we doing? I'm going to go through this really very, very briefly. When we were exploring this with programs that we already work with, there's 100 grantees who are doing this integrated care around the country. And when I was working with many of them, we just noticed there wasn't a lot of social workers that seemed to be like, core to the team. And so we were kind of like asking those kinds of like questions. And it seemed that some of the functions that we thought perhaps social workers would be involved in, that you saw nurses, registered nurses being, involved in. And it just didn't come across like, so what is the unique contribution of like social workers in an integrated setting? So that got us to really beginning to thinking that, is this something that's on the radar screen of schools of social work in particular, and the social work profession itself? And so we had conversations with different organizations that are related to social work, with SAMHSA and other organizations. So what can we possibly do to address this kind of thing? Because if you don't establish your role and competencies, then you may be left behind. And it really came down to, to that. We had conversations with the National Association of Deans and Directors of Schools of Social Work, the Council on Social Work Education, and they're all very, very excited about getting into this area. So one of the things that has been done is there's a project where social workers have developed a faculty around the country a curriculum to be used in schools of social work. I'm here at NYU School of Social Work, and we have a practice and policy curriculum that's a part of the curriculum for MSW students. So just beginning to expose people to some of these areas, both in terms of policy and in practice. These materials are all done. They're all available. They're all free, which we think is going to encourage other schools of social work. If you provide them with an entire curriculum, including all the PowerPoint, all the readings, all the possible assignments as a core, and then they take it and they begin to modify it in the way that they would like. That's what we saw happening. So we had a large number of schools of social work around the country that began to introduce this into their course curriculum. We think that's a good thing. Here are just some of so we did some course curriculum development, launching it in a number of schools of social work and getting all that feedback. But we also knew that we had to go a little bit further and go into field placements. And so, these are just some of the content areas. I don't know if this is so critical to know, but you can see that we really addressed a lot of the areas that I just discussed with you. So, it's an entire semester-long course, and it includes a lot of these topic areas. There's both a course on policy and a separate course on practice. At NYU, we combined both of them into a 6-credit course over a semester that looks at policy and practice together, and some other schools have been doing that. So we thought that that would be a good idea. But then we had the opportunity to get some funding to support schools and students who would work their field placements in these integrated settings. and we think that's really, really very, very important. So let me go to that slide. So the bottom line, let me just really go, because I'm conscious of time. Here's the bottom line. The field placements is critical, where students begin to actually apply what they have learned. Those core competencies that I mentioned, that's the kind of thing that is advanced in their field placements, where they do get an opportunity to discuss or to conduct, let's say, an integrated assessment, where they're asking questions around physical health, substance use, and mental health. So that's one piece of it. To begin to run a group where the focus is on health management and looking at people with chronic health conditions and really seeing the connection between people who have chronic health conditions, the emotional consequences of that can lead to some mental health difficulties, as well as raising the risk for substance use. When you're in pain, you've raised your risk for substance use. There's no question about that. So those were some of the experiences, and many others around imparting information, and everywhere from looking at smoking cessation. It was different among the different field placements, but I think that's really the important piece to come away with this. So I'm going to stop now, because I know we have maybe there's some room for some questions and answers. The only piece I want to say is that where we started is to take a look at the schools of social work, looking at curriculum, trying to expose the schools of social work from around the country so that these are available, make the case for why this is important. If they don't want to be left behind, if they want to give their students the best position, and all of these core skills, the more you have of them, the better you are. You are quite marketable if you come in with a whole set of these knowledge areas and core competencies related to integrated care, because if you do it in an integrated setting, you do it in any setting. So those are some important factors. So I hope that this has given you some good ideas, a good understanding of what we mean by integrated care, what the role of social work needs to be in order so that they play a very critical role. And the other piece is, in order to play that critical role, be able to deliver really positive outcomes, to have those core competencies is going to be critical to make this happen. So I'm going to stop on that note and then just turn it back over to Tracy.
Great, thank you. Thank you, Tony. And we appreciate folks submitting their questions while Tony's been presenting. And so we have several questions. I tried to answer a few of them during our break, but there are several that I certainly can answer, and I believe that you can shed some light on here. Let's see, the first one, let's see, we had a question about what resources are you aware of, or do you think maybe their sites or maybe their curriculums around trauma-informed care for social workers? Where might we point folks for more information? Tony, if you could unmute yourself, please.
Okay, sorry about that. Yeah, there's a compilation of a whole variety of trauma-related interventions. And so there's two ways to look at this. There's actually a resource that I can send along. If I sent this along to you, Tracy, would you guys be able to then distribute that to the folks who've been on it? Or should I just give them, I don't have the actual link in front of me right now. What would be best? Because what I'm going to suggest is a compilation of all the sort of recognized evidence-based as well as promising practices around trauma-informed care. Treatments, many of them are group curriculum-based treatments. Others are related to more some individual or specialized work. And it provides you with contact information if you wanted to learn more. It gives you a good description, what research has been done on it. Some have a lot of research, some have minimal, and some have none. So I have that resource, and I think that could be really very, very helpful. What would be the best way for me to get that out to you guys?
Oh, I think that one of the best ways is for you to send it to me, or and or Misty, and what we'll do is we will take the resources, we can post them to our website. We'll post them on the same page where Misty's going to follow up with everyone with an email that says where the recording and where the PowerPoints are posted and the CE. We will create a link there. So send them to us and we'll upload them onto the website.
Great, great, great. I think that's the best resource I've come across. Certainly SAMHSA has their sort of listing of the National Registry of Evidence-Based Practices. And also around trauma. And I think they have about 8 different programs associated with it. None of them are specific to the practitioner, their discipline. But that's at least, I think, a place to, to begin.
Yeah, great. Thank you. We have another question, and I think maybe there's a resource or maybe there's a website sometimes when schools are implementing a common curriculum. There's a place where we can go to learn more about that. And what this person is trying to find is to understand what graduate schools of social work are actually implementing it. Are there grantees that have been granted funds to implement the curriculum? Is our website devoted to where we can learn more about those graduate schools? Where could we get a list?
Okay. Well, we certainly know the graduate schools that were part of our project. And it's either something I need to send to you or the Council on Social Work Education, that's CSWE. They were partners with us in developing these materials. So the one thing you can definitely get there would be all the curriculum material is available for free. So that if you were going to be an instructor of a course on policy or practice, you could go to CSWE. I believe they also describe this project with a listing of the schools that participated. I think we had somewhere of close to maybe 50 schools of social work around the country that included integrated care as part of a curriculum offering. Usually they were electives. And then there was 27 schools of social work that were engaged in the field placement, where they had at least one of their students who was placed in an integrated setting. And there was at that time financial support both to the student and the integrated setting. There's no current funding, additional funding for any of this. But certainly, our hope is that this will begin to catch on, that when some schools of social work find out that there are other schools of social work that are doing this, that seem to be ahead of the curve, that are looking at the future of healthcare and what the new roles for social workers in a changing healthcare system would be, that they would have a little bit of a competitive sort of like edge. We do present at some of their national meetings, so we'll be in front of many deans and directors of schools of social work and make the case for why this is really important, so that should be expanding. So I would check on the CSWE website, but in addition to that, I'll send along, Tracy, to you the list of the schools that are involved in this integrated care project. There are some who may have started it because of their exposure to some of our work, and we may not even know about it. There may be some schools out there, they learned that they can take the entire curriculum. There was an interested professor, and they said, yeah, I want to teach a policy or a practice course on integrated care, and we wouldn't necessarily know that. CSWE might. They may know who's downloaded some of the materials or they got some feedback. So I think the first step would be to CSWE, but I'll be sending you, Tracy, some of that information as well.
Great, thank you. We can post that. And if you send documents that we need to house and upload, we can do that too if it's not already on the web somewhere. And I've posted the URL for CSWE. They have a wealth of information available, and so if there is anything that we can do to help facilitate getting additional information, we're glad to work with them as well, whatever you recommend. But we've posted at least the URL to get us started. Another question we have here, let's see. Well, let's see. I couldn't have possibly gotten all of the questions here, could I? So if someone was interested in finding about specific programs that are doing integrated health care up in New York, Westchester County, for example, where do people go to find out where these programs are located? Is there a central website? How do people learn more?
Well, there's the list of folks who are involved in the National SAMHSA project. There are 7 actually still active in New York City, but they're all in New York City. And so those are actually organizations that I work with. And so there are 7 of them located throughout some of the boroughs in New York. The Center for Integrated Health Solutions, CIHS, is the website, and they would list all of the organizations or programs that are currently doing integrated care. Now, those are the folks that are officially part of the national, project, and they're usually the most advanced around integration. There may be others that have not really formed a, sort of a specific, that there's a list of those who are moving towards integration on their own, who are not part of like a sort of a national grant project. So I wouldn't be familiar, with them. But there are really 2 sources to find out organizations that may be more involved in this integration. There's a move in New York State, it would be around health homes. And so if you have find agencies that are the lead agency in health homes in New York State, that would be a good place to begin. Part of health homes is really to begin to establish more integrated care. That's, if you just Google health homes in New York State, and that would be, I think, you'll get a link, and there you'll be able to identify those organizations that are part of a health home, and that will be at least a good starting point. If the person would like to just email me directly, who's asking that question, I can give them more information about the New York City. I can, give you the list of the New York City organizations and things like that, if they would like.
Great, thank you. And I'm going to post the URL for the Center for Integrated Health Solutions. I'm going to post that URL that's connected with SAMHSA, and I'm going to send that off right now. Everybody can see this. All right, great. And we have just a couple more minutes, so we're going to be closing down shortly, but I did want to just finish a thought that I had earlier about the evidence around SBIRT. And I mentioned there was a lot of evidence and research that's and dedicated volumes of research to the effectiveness around alcohol. But I mentioned there were clinical trials. They're still going on around looking at the effectiveness around illegal substances as well as prescription medication misuse. So that work has been showing some promise, but we are still waiting to get findings out and publicly available to see what those studies are showing. There's been a lot of work done around tobacco and the success of SBIRT around tobacco harm reduction and cessation. And so we have posted many articles on these topics at our website, at the hospital SBIRT.webs.com website. We'll also make sure that we have some literature reviews that look across studies as well. The Madras article, can't think of the date right now, but we'll make sure we post that as well, which summarizes across many studies. So yes, there are, and I would encourage you to visit our website for those resources. So we're going to wrap up our presentation today. Thank you so much, Dr. Salerno, for your presentation and the rich information that you've shared. And we just want to remind folks that we are going to make available the slides already are up there, but also the recorded session of today's presentation. That will all be posted on the dedicated page for this particular webinar, which is housed at the hospitalsbirt.webs.com website. We will be offering the free CEs, as I mentioned earlier. We'll ask you to complete the CE quiz, which I know is already being posted over here in the chat box. Are links to all of these things, but you'll also receive a follow-up email that will summarize where to access this information. We also have a really important evaluation survey. There'll be a link to that as well. It's really critical that we have your participation. And in fact, if you had 30 seconds to complete it now, we certainly would be very grateful. And that probably sums up most of our housekeeping items as we wrap up. But I want to mention to you that please take advantage of these webinars that we've produced with wonderful presenters like our presenter today. These, even though they might have happened months ago, the information is as relevant and valuable today and tomorrow as it was 3 months ago. And we probably get as many archived recordings, probably more than we do of even live attendees. That tells you that people are coming back, some are listening to it again and again. Rich information, all free, available to you. And we hope that you'll take advantage of that, but also our last webinar in the series, which is continuation of this topic around integrated care, so why integrative care. So that's coming up on August 6th. I encourage you to register. You can register at the URL that we've been talking about, the hospitalsbirt.webs.com website. And again, I want to thank Dr. Salerno for his terrific presentation today, and thank everyone for attending and your questions and engaging with us with the polls and being a part of today's presentation. And I want to thank our sponsors and the collaborative partnership among these organizations, without which we would not be able to bring such quality professional development to the field. So thank you, everyone, for attending. Have a great day.